severe MR and SAM. Intra-procedure, the gradient decreased to 25 mm of Hg after the ablation. MR was mild. And then next day it was 10 mm Hg of gradient, LVOT gradient, with trace of MR and almost no SAM.
Means this alcohol,
Septal ablation, આપણે perform કર્યું હતું HOC.
that fast,
Yeah.
the action of that is.
Yeah, it really is, we have that documented thing.
That's okay, but you know the.
આપણે assume કરે કે there should be some regression in septum, પછી the gradient will work out, but we did so that it was.
Thickness માં કેટલો ફરક પડ્યો pre procedure and post procedure?
Thickness wise there was probably hypercontractility, the part of that could have contributed.
Legal age 8 female?
No, it was male, around 50 up.
Strong family history?
Yeah. Symptomatic.
કયું symptoms સાથે આવ્યા?
And then grade 3 dyspnea. Anyway, we'll start with the today's topic. It's about Dogoxin toxicity. While we might think that the topic is out of tradition and the drug is widely used these days, I come across about 4 to 5 people with Dogoxin toxicity in just last couple of weeks. So I thought let's just brush up the concepts. There's the mechanism of the drug. It will bind the sodium potassium receptor on the cell. The receptor causes the outward flow of sodium and inward flow of potassium. It blocks that receptor, hence there is increase in the sodium intracellular sodium concentration, which again hampers the function of another receptor, which is the sodium calcium exchanger, which throws the sodium out and brings the calcium, which usually throws the sodium out and brings the calcium in, but due to increase in the intracellular, which brings the throws the calcium out and brings the sodium in, but due to the deranged gradient across the cell membrane, the function of that receptors get deranged, and that is increasing the intracellular calcium, which leads to the main mechanism of action. Apart from that, there is some baroreceptor functions, neuromodular functions. There is also increased parasympathetic tones. The neurohumoral actions, primarily the baroreceptor ones, they decrease the sympathetic nervous system activation of the baroreceptor functions. It has a vagomimetic effect, primarily acting on the SN AV node conduction pathways. Also has some sympathogenic inhibitory effects, which primarily decreases the nerve discharge of sympathetic fibers. It also decreases circulatory sympathetic neurohormones such as norepinephrine, and also affect the plasma renin activity at therapeutic doses. It also has some sort of antifibrotic activities, which is particularly important in post-myocardial infarction patients. Looking at the hemodynamic.
What was the second last effect?
So that I need to evaluate. But basically, it affects the norepinephrine sensitivity of the cardiac tissue. That's what it means to say. And the hemodynamic effect in a normal in a person with a normal cardiac with no left ventricular dysfunction, it usually, despite increasing the cardiac contractility, it does not increase the cardiac output, and the effect is mostly due to the increase in the systemic vascular resistance in the patient with heart failure. It improves LVEF, reduces pulmonary capillary vein pressure. Though in heart failure patients who have no significant pulmonary capillary vein pressure, that effect is mostly mutilated.
So how it is possible if a drug is increasing the contractility but it is still not increasing the output?
Mostly due to that peripheral resistance.
That means you are trying to say that if by increasing contractility, the obstruction increase because of resistance? છે કે કાર્ડિયાક આઉટપુટ ચેન્જ નથી થતું એટલે તમે હાર્ટ ફેલિયરમાં લખ્યું છે કે એલ્વિએશન ફ્રેક્શન ઇમ્પ્રૂવ થાય છે. How it is possible?
That statement is particularly related to patients without any LVA, significant LVA.
The first statement.
Yeah. That was for the normal
So
subjects.
that means in non-failing heart it will not increase.
Not without any systolic dysfunction, evident systolic dysfunction. Electrophysiological effects, basically the parasympathomimetic effects, and particularly acting at the SI and AV nodes, and very little effect on the cognitive fibers. Again, in brief, the pharmacokinetics of Dogoxin. 60 to 80% absorption from the tablets. Absorption time is 1 to 3 hours. Distribution time is 6 to 8 hours, and protein binding is very high in this particular drug. The normal half-life is around 36 to 46 hours in patients with normal renal functions, but in anemic patient it can increase up to a week also. Now, steady state of the medication is achieved within 7 days. I have not compared the Dogoxin and Dogoxin is, but I have read this in news. Just the 3 trials of the medications. First was the big trials. That included the patient with LVEF less than 45%, and the outcome was significant increase in the heart failure hospitalization and all-cause hospitalization. But there was particularly no difference in the toxicity was seen in 2 patients with Dogoxin. Again, the treat AF trial and absolute trial, both the trials said that in the long term, the patients who were treated for AF with Dogoxin had slightly higher mortality rate as compared to the other agents. What are the current uses, FDA approved uses? Just the 2 uses. This is the 2022 heart failure guidelines, and the medication is used only in the patients who are symptomatic after the traditional 4-pillar therapies of the LVEF, or the 4 pillars cannot be applied. And that's a class 2B recommendation. For AF, it can be used in a patient whom the traditionally the beta blockers or the calcium channel blockers are non-effective, non-contraindicated, or even if the patient is having AF with use of these medications. This is the dosage, traditional dosage rating. IV, first one is the IV, 0.25, 0.5 mg over few minutes. Can be repeated in 6 hours and maximum 1.5 milligrams can be given in 24 hours. Oral dosage is 0.0065, 0.25 mg daily. Renal doses I have mentioned for the slides. So this was the article that was published in August 2024, and that included almost 30,000 plus papers and studies that were published for the toxicities over the period of last 6 decades, and it had certain recommendations. Those are the basically parts of today's presentations. So that paper particularly defines Dogoxin toxicity, classifies into this following manners. Particularly, we are more interested in the chronicity of the toxicity, whether it is acute or chronic and chronic. There's slightly changing the management of those things. Now, the risk factors would definitely include an advanced age, which also is due to low muscle mass and decreased renal clearance of the drug. Of course, the renal dysfunction is separate, and mostly the main important risk factors for Dogoxin toxicity. Hypokalemia does precipitate toxicity, and there are certain drug interactions that will be seen in the following slides. This is from the paper that I mentioned earlier. 70 plus of age is particularly considered as a very high risk patients for Dogoxin therapies. Person with impaired renal functions, of course, are associated with the Dogoxin toxicity chances, and of course, the nature of the exposure in toxicity is more important, and the concurrent medications used. is the enhanced innate activity of the drug, which leads to certain complications, and hypomagnesemia again sensitizes the myocardium more towards the effects of Dogoxin. In drug interactions, of course, we have diuretics that causes decreased production in urine and increases the chances of toxicity even at the normal doses. There are certain drugs that decreases the renal excretion of Dogoxin. Then there are drugs that have effects that are similar to Dogoxin, or they are mimetics, and that causes again toxicity effect more pronounced. These are some of the drugs that causes increase and decrease level of Dogoxin. Now, even if we move ahead, and I have mentioned probably in the next few slides, the take-home message from that paper was that Dogoxin levels are not to be considered as absolute. What we consider a normal level is not an absolute thing. There are people who might be having Dogoxin toxicity with the so-called normal Dogoxin levels also. In clinical presentation, of course, the acute overdose will more commonly present with the prominent GI symptoms and cardiac arrhythmias. Cardiac arrhythmias can be of almost of any nature, from bradyarrhythmias to rapid ventricular tachycardias. Chronic overdoses, GI effects are usually present, but there is more common presentation with the CNS effects as well as the cardiac arrhythmias. Basically, these are the pillars of a suspected case of Dogoxin toxicity diagnosis.
What was the previous slide?
There was chronic toxicity events.
Will Dogoxin toxicity will lead to hypokalemia?
No. Chronic, of course.
Chronic will lead to?
Chronic will show hypokalemia. Acute hypokalemia. In the history, of course, we need to decide the nature of the toxicity, whether it is acute or chronic, or it's a chronic toxicity. We need to look out any recent drug intervention that was either added or removed from the patient's regimen. Then there are
the thing is acute and chronic.
Yeah.
So that depends on the usage of that drug.
Yeah.
If somebody has taken more than 6 weeks, then it is chronic.
Yeah.
That's how it is defined.
Yeah.
Acute and chronic toxicity, how they are defined. Suppose some patient of Dogoxin toxicity comes. So how do I know that it is acute or is it the acute administration related?
From the history only.
Acute administration related or chronic administration related?
While the definition wise you are right, that 6 week point of view, the treatment is morely towards acute ingestion, and the related treatment is morely is towards initial 6 to 8 hours of overdose basically.
No, my point is, how do I decide that this patient is an acute Dogoxin toxicity or chronic Dogoxin?
So as far as my presentation is concerned, we are only defining this toxicity based on the therapeutic aspects. As per the therapeutic aspect, I would say where I am talking about the acute thing, it is most likely at least 24-48 hours. That's what I am talking about.
That is the overdosage of the. In that case, patient has taken.
You are talking in terms of ingestion of Dogoxin, or you are talking in terms of the development of the toxicity symptoms?
I am more talking in terms of intake of the medications.
And generally you are not going to have any acute issues then. Because आज Dogoxin
think
देने
this
में
is
any-
the
Usually the
symptom.
most common form we see is the patient taking everyday Dogoxin rather than.
So it's a chronic thing,
Yeah.
right? So mostly જે સરનો question છે એનો answer એવો હશે કે patient નો જે presentation છે, right? As we said, you said કે any sort of arrhythmia can be possible. So because of that arrhythmia, what are the hemodynamic issues that came into picture? What is the actual clinical presentation? That will rather classify whether it is an acute toxicity or chronic. Is it so? Or
what is I know. So if someone is having acute presentation, patient might be taking it since long, but presentation may be today.
Yes, of course. The most common presentation is taking medications daily for a couple of weeks and the patient comes to us. Okay. These are again the same things. EKG can like any form of
that vision is the last time आपने yellow vision अपने वसंत भैया कल दुखे if somebody is complaining of yellow halo
that's a classical flow.
last time वसंत भैया has highlighted yellow vision
That's photophobia such as yellow colors.
Any form of arrhythmia.
Specifically to anamnesis.
Yellow vision.
Any reason?
Probably
most common is nausea, vomiting, but we always ignore. But patient on Dogoxin complain of only nausea. And
our heart failure
agree.
So liver congestion is so common. Yes. Sometimes
intestinal congestion,
persistent nausea होता है. In that case, I say persistent nausea.
Only one complaint is nausea.
Yes. ના પેલાનું વિઝનમાં સ્પેસિફિક યલો કલર એવું કંઈ છે
ના એવું કંઈ સ્પેસિફિક પણ આઈ ધેટ ઇઝ
કોઈ
વોટ
આઈડિયા
કોઈ બી સાહેબ પ્રેક્ટિકલી જોયું નથી વસંતભાઈ બોલ્યા હતા પણ આઈ હેવ નો આઈડિયા
પણ જેટલી પણ જગ્યાએ મેન્શન કરેલું છે they have mentioned as yellow color.
એટલે લાસ્ટ ટાઈમ ડોક્ટર વસંત પટેલે હાઇલાઇટેડ એ વસ્તુ મારા મગજમાં રજીસ્ટર થઈ ગઈ યલો વિઝન.
It was mentioned in perhaps all the documents with chronic Dogoxin toxicity.
તમે જે પેશન્ટ જોવો છો એમાં પૂછો છો પેશન્ટ
પૂછી છે પણ નથી જતું પેશન્ટ
પીડા ચશ્મા નથી પહેરતા
હવે કેટલાને હોય છે ડિગોક્સિન
સર ડિઝોક્સિન હોય છે સર વાલ્વ્યુલર પેશન્ટ વિથ
વાલ્વ્યુલર મોટા
વાલ્વ્યુલર
એટ્રિયલ ફિબ્રિલેશન ને વાલ્વ્યુલર
બાકી સર નોન વાલ્વ્યુલર માં તો ઓલમોસ્ટ ઇટ ઇઝ આઉટ
Actually our discussion was some guidelines, but મારે છેલ્લા 2 વીકમાં I come across 4 patients with Dogoxin toxicity. And one of them was prescribed by a cardiologist. I wouldn't go in details, but that was recent MI with renal dysfunction. A young guy was prescribed Dogoxin for symptoms.
and hypokalemia is underlying features which precipitate the
મને નહીં લાગતું તમે હમણાં કોઈ છેલ્લા 5 વર્ષની અંદર કોઈ પેશન્ટને તમે વાલ્વ્યુલર સિવાયને પ્રિસ્ક્રાઇબ કર્યું હોય
હવે તો એપ્લિકેશનમાં નથી ને
તેને નેરો ડાઉન હે ડિઝોક્સિન લખ્યું હોય
વાલ્વ્યુલર AF is the only
only reason yes
ક્રોનિક એટ્રિયલ ફિબ્રિલેશનનું પેશન્ટોને ડેટ કંટ્રોલમાં તમને લોચા તત્વ બીટા બ્લોકર અને કેલ્શિયમ ચેનલ બ્લોકર ત્યાં આઈ ડુ યુ
હા પણ એ તો સર કેવું છે કે એઝ અ સિનિયર ફિઝિશિયન તમારી પાસે 3-4 મેડિસિન લઈને પછી પેશન્ટ કે સર હવે આ હરકું નથી થતું શું કરો
બાકી એક્યુટ ઇવેન્ટની અંદર તો કોઈ અત્યારે નવા કોઈ પ્રિસ્ક્રાઇબ
યંગ બ્લડ તો નથી લગતું ડિઝોક્સિન
બીજું તો તમે ઇન્જેક્શન ફ્રેક્શન 15% વાળો છે all the medicine is going on and still he remains in failure. I do prescribe
આ તમે ચાર નામના કહો છો એ નવા હતા યંગ વા ઈસ કોઈ યંગ
One guy was one guy is a young cardiologist.
But all the patients were chronic Dogoxin toxicity or anywhere acute?
This was the last guy I mentioned was more of an acute toxicity.
How?
It was a recent MI admission, and he came to me after 4 days of discharge of certain hospital. And he had baseline renal dysfunction. His reports had hyperkalemia.
So post MI Dogoxin was given.
Yeah.
Wow.
So
હજુ છે એટલે
કયા સિટીમાંથી તો આપણે નામ સિટી કયો સિટીમાંથી પ્રિસ્ક્રાઇબ કર્યું
it is not me but some આપણે last
Let's
10,
not
15
name
years
the
ago
city.
તો
Who
શીખડાવે
has prescribed it? I am not asking, but from which city you got that patient?
Let me just say that
practically digoxin is useful but
salted peanuts are very famous from that city, a nearby city of Baroda.
Okay.
what is famous
Kari Singh, Baruch sir. Baruch the other patient. Anyway,
ભરૂચમાં there are so called so many physicians
But rather
They-
it
they
is
don't prescribe.
acute MI, post MI it is contraindicated.
yeah. And I do come across when I was in Surat Prime, there I used to come across so many Dogoxin patients and toxicities. કારણ કે ત્યાં valvular અને even this DCMPs are very common. Due to unaffordability of the traditional SGLT2 and AMPs, they are prescribing Dogoxin for symptomatic
To
relief.
continue Dogoxin is very, economically
આ
very easy.
તમે જે
Patient છોડે જ નહીં દવા, તો આ દવા
એમાં
લઈ
જે
શકે.
mentor હોય ને,
Yeah.
mentor ની delay
Dogoxin ને Lasix તમે
આ એક
વર્ષોથી ચાલે.
વર્ષોથી એમાં
અને એમને તમે
ના-
છેડવા
ના-
જાઓ
ના- તો ના જ લે, કારણ કે એ તો સાહેબ
તમે છેડવા જાઓ તો આવી બધી તમે.
Like peripherals માં definitely હજુ use કરે છે. Due to particularly non-affordability to newer medications. Again, the traditional EKG presentation, we won't go in much details. These are the therapeutic levels described, 0.5 to 2 milligrams. The toxicity is particularly said to present if the levels are more than 2 milligrams. The traditional FDA approved range is 0.5 to 0.9 nanogram per ml, not 1. But again, we need to think that these are not the absolute limits. We can have a patient with 0.9 or less nanogram per ml of Dogoxin in blood who comes with Dogoxin toxicity, maybe even mild to moderate. But that is still possible. Again, we need to look out the electrolyte imbalances, hypokalemia that causes the Dogoxin toxicity.
So what is the prime reason?
It increases the binding of the drug to the receptor.
Yeah, but so why there is hypokalemia in Dogoxin patient?
Acute में there will be
એની મિકેનિઝમ ઓફ એક્શન માં છે ને કે
Yeah.
ઇન્ફ્લો બ્લોક કરી દે.
Inflow block.
So major issue is most of these patients are on diuretics,
Yeah.
right? So
Potassium
that precipitates hypokalemia and that precipitates Dogoxin toxicity. So even at a lower serum level of Dogoxin, you will have Dogoxin toxicity. Unless and until proved otherwise, this patient will be on Lasix.
Sure. Hypocalcemia, I have not come across very frequently. Hypomagnesemia, of course, it is important as it sensitizes the heart more towards the Dogoxin effects.
most of the chronic diuretic use will lead to
To
hypokalemia as well as hypomagnesemia. So in a chronic diuretic use, you will find both the problems, chronic hypokalemia as well as
Hypomagnesemia, those are common. I have not like hypercalcemia is
the modern world literature in foreign, they now used to TDI, therapeutic drug monitoring, TDM in even antibiotic in many medicine. આપણે એ કરી જ નથી શકતા. Dogoxin level therapeutically patient નું કેટલું compliance છે, શું છે, we are not.
ideally after starting the medications at the end of 7 days.
Eptoin level છે, પછી
Check કરવું.
tricyclic
I am still stuck up at that post-MI patient. How you presented with Dogoxin toxicity? What symptoms were there?
We presented with classical GI symptoms. And on his part, sorry, I have to change my words. He didn't came in 4 days. He came like around 7 or 8 days. He was taking that medication daily. Apart from that, it was post-MI patient. Apart from that, his grade was 2.4 in discharging time. I couldn't do the levels because he didn't got admitted, but it was definitely that.
See, in that case, you have not checked the levels. Of course, mostly it is going to be high because creatinine is also high. But nausea, vomiting were the symptoms.
Yeah,
Or anything
persistent
else?
nausea and vomiting, as the sir said.
There can be many other things because leading to that presentation. In post-MI patient who is put on DAPT, recent hospitalization, AKI itself. Why you are stamping it as a Dogoxin toxicity?
Of course.
Isn't it?
Yeah.
Was there hypokalemia? There must be hyperkalemia.
There was hyperkalemia.
Yeah, okay. So that can be again because of kidney issues or Dogoxin toxicity. તમારા levels of
It was your assumption it might be Dogoxin
Rest
toxicity.
3 of
It
the
was not
patients were
your-
admitted and that had the documented Dogoxin toxicity. The 4th guy, honestly, I am saying that I didn't go and check the liver because it did not got admitted. But it was a possible case. Let's put it that way.
પોસ્ટ-MI હતું તો ECG કેન્ડિસમાં કઈ Dogoxin ઇફેક્ટ કે ટોક્સિસિટીના તો કદાચ બહુ ખબર નહીં પડી હોય હતું કઈ.
Nah, there was no
What was his ejection fraction?
25%. And
Okay.
the criteria was anti-anticoagulant.
In your criteria of Dogoxin toxicity diagnosis, you have clearly mentioned that Dogoxin
Yeah.
level is must.
It's not a must thing to have
4 or 5
high.
I think you had.
clearly mentions that you can have a patient with like mild signs.
That is fine, but whether it is mandatory to check the levels
It
or
is
not?
mandatory.
It is mandatory. That
It
is
is
clear.
mandatory to strike.
B, why you have not checked? Was there this PMJ Yojana or Ayushman,
No,
something
no.
like that?
No, no. That guy was a young guy and he came with his couple of friends and they were hesitant to get admitted and so and so. But the rest of the 3 patients were our admitted patients and they had clear documented.
What is the current cost of Dogoxin toxicity? 500,000 હશે કે વધારે?
Antibodies.
નહીં, Dogoxin level check કરવાની cost કેટલી છે?
1500 થી 2000.
1500 થી 2000.
1500 થી 2000.
Depending upon that. These are the statements from the article I have mentioned again. Hypokalemia is again increased with the increased effect of Dogoxin in the heart. The high potassium levels are more of a sign of an acute toxicity of the patient with. This acts, please read it as a 6.5. I have mentioned it in next coming slides. As per the AHA guidelines, who is having potassium level of 6.5 symptomatic with Dogoxin, standard Dogoxin toxicity, it's a classic indication of antibody therapy. The normal treatment, the normal range to be maintained in the patient taking Dogoxin level is 4 to 5
Is it 6.5 or more than 5?
It's,
The X say.
Dogoxin antibody માટે it's more than 6.5.
Is it? કયા yearની છે guideline?
This is basically more of a meta-analysis kind of thing. And they have given
No, I think it
another one is the AHA guidelines.
6.5 લગી wait કરવાનું છે. It's a critical, it can lead to arrest. Well, I may be wrong, મેં બહુ ટાઈમથી વાંચ્યું નથી, પણ more than 5 or 5.5 કરતા વધારે હોય તો you have to give relief immediately.
In normal CKD patient માં એવું છે, if up to 6, you can give other therapy.
CKD ચાલે સર, આ તો Dogoxin toxicity માં classical Dogoxin toxicity ની વાત થાય છે.
But if it is crosses beyond 6.5, then it's a alarm.
That is fine, but Dogoxin toxicity માં you cannot wait till 6.5, the patient collapse થઈ જાય.
We'll see, sir.
જોજે ને એક વાર sorry.
Yeah, sure. Sir. Again, the low magnesium level needs to be corrected. Particularly, the calcium is not useful to treat hyperkalemia of the Dogoxin. That's what the intent of this slide. Management of the cardiac arrhythmias. For bradyarrhythmias, atropine can be given. Adrenaline and isoprenaline should be avoided. Cardiac pacing should be given. If you look at the recommendations given, for the bradyarrhythmia again, atropine, class 2B recommendations, and cardiac pacing is also having class 2B recommendations. For the tachyarrhythmias, we can use lignocaine. For acute toxicity, if up to 6 to 8 hours, we can use activated charcoal. Hemodialysis is not particularly effective to clear out the drug from the plasma as it has very high protein. Very few slides about this Dogoxin antibodies. It is available in Ahmedabad. It is available with stockist in Ahmedabad as well as in Mumbai. I talked to my pharmacy guy yesterday. He told me that he has one stockist probably in Ahmedabad, definitely in Mumbai. But I'll come back with the price. And in today's era, the transportation should not take more than a day, perhaps. The level of Dogoxin, at least in asymptomatic patient also we try the antibodies is 10 mg, 10 in healthy and 4 in children. In chronic, more than 6 and 4. Again, the other indications of antibody severe arrhythmias, progressive bradycardias, second and third.
No, 5.5.
Yeah, okay, 5. Yeah, again, sorry.
Why the reason that CKD માં સરે કીધું કે up to 6.5 તમે બાકીનું કરી શકો, પણ અહીંયા સ્પેસિફિકલી બધી જ મોડાલિટી કોન્ટ્રાઇન્ડિકેટેડ છે. Why? કેમ કે તમે GI drip આપો, nebulization આપો, calcium આપો. Why it is
GI drip per nebulization can be tried, but calcium.
Why it is absolutely contraindicated in this situation? Because
Calcium- calcium is not-
bringing down potassium further will increase Dogoxin toxicity. You have to give this antibody. There is no option.
I'll again check and come back to you, but calcium, IV calcium is contraindicated.
Hypokalemia will precipitate digoxin toxicity. તમારું ઓલરેડી digoxin toxicity છે અને તમે ફર્ધર પોટેશિયમ ડાઉન કરવા જશો તો વધારે થશે.
No, but hypokalemia why we are giving those things? These are for like
તો તમે શું કહો છો કે ભાઈ 6.5 લગી બીજા બધા મોડાલિટી આપણે ટ્રાય કરશું to bring down potassium.
Yeah.
If you will bring down potassium, your digoxin effect will increase.
Yeah.
Agreed? So that is why 5 अथवा 5.5 करता વધે you have to give this antibody. You cannot try anything here. Your patient will collapse immediately.
Sure.
It's a very important point. Keep in mind.
Again, the basic mechanism of action. How the dose is calculated. If the amount of digoxin ingested is known, then it's divided by 0.5. And depending upon the formulation, whether it was IV or oral, again it has to be multiplied with 0.25 or 0.2. If we don't have any ingestion dosage information, then for more than 20 kg patient, we use 6 vials of antibodies, and for patient less than 20 kg, we use 1 vial of digoxin antibody. So, the precautions while prescribing the medications. These are the patients in whom digoxin should not be prescribed, or rather prescribed with absolute cautiousness. Patients who are already having sinus node dysfunctions and who do not have any pacemaker implanted, WPW syndrome patients, HOCA patients, and MIO heart disease patients. These are the relative contraindications, of course. Caution is definitely required in patients with renal impairment, electrolyte imbalance, thyroid, and acute coronary symptoms. Like for patients who are taking digoxin and for arrhythmia, electrocardiogram, if at all it has to be tried, then it has to be the lowest possible energy setting. And if it's a planned cardiogram, then of course you have to stop digoxin a few days back, otherwise it is likely to precipitate in the range of ventricular arrhythmias. Again, the digoxin should not be started in a patient who once presented to you with digoxin toxicity for whatever reason it was prescribed. If at all, it has to be started with the lowest possible dose and with utmost cautiousness.